that are important in this conference. The background of this talk is different than other talks that I've given. Generally, I tend to present things of interest to my own clinical work, my own research, but the origin of this particular talk really relates to the patients. So for many years, my patients had been asking what can they do to enhance their chances to conceive in infertility in general and IVF specifically. And for years, I answered the question by saying, really, not very much. It's really in the hands of those of us who are caring for you. But the questions kept coming and they were so persistent, I decided to do a little bit of a literature search. And I discovered a couple of things. I discovered that there is a small, but I believe, and I'm going to share this with you, helpful literature on the effects of lifestyle interventions on pregnancy outcomes in IVF. And when I delved in a little bit deeper, I was shocked to learn that a fair bit of that work was actually done in my own division. And I was quite embarrassed to learn on deeper delving into the subject that two of the pivotal papers, which I will share with you, were my own work. So feeling a little bit humbled, let's take a look. These are my disclosures. And these are the objectives for the next half an hour or so. We will talk about lifestyle issues which may impact IVF outcomes. In particular, I'll walk through the effects of cigarette smoking, alcohol, caffeine, diet, and exercise in IVF outcomes. And my hope is at the end of this presentation and our discussion that each of you will be able to utilize the data that we've discussed today on lifestyle to counsel your patients and answer the question a little bit more academically than I did. And yes, there are modifiable factors that the patient can change. And I think the patients are often very happy about that because then they can partner with the physician and the care team in their own care. So as I said before, these are the topics that we'll cover, and we'll go right to cigarette smoking, which I know the previous speaker discussed as well. So the prevalence of cigarette smoking in reproductive age women varies depending on where you look and when you looked. In Europe, about a third of reproductive age patients, at least about 15 years ago, were cigarette smokers. More in Southern Europe, less in Northern Europe. In the United States, that figure was a little bit more than 1 in 4 in 2008. But when my colleague and friend, Dr. Ali Domar, took a look at this in Boston, only 3% of patients said that they were cigarette smokers. And I think that number is low for several reasons. One is that Boston and Massachusetts in general tends to be a very health conscious area. So there's less cigarette smoking here in general. Secondly, I think infertility patients are highly motivated not to smoke, and if they were smokers, to give up smoking. And lastly, and perhaps most importantly, my own suspicion is that a lot of patients will not admit to the physician, particularly in the infertility setting, that they're in fact cigarette smokers. So the earliest study that I could find comes from the Netherlands. This was a study that included almost 8,500 women in their first IVF cycle. And what you can see is that the live birth rate dropped by 28% among cigarette smokers in this study. And in addition, there was a statistically significantly higher miscarriage rate among cigarette smokers. The next study was actually an analysis of a number of different studies, meta-analysis, looking at several outcomes in cigarette smokers compared to non-smokers. And what you see again is a consistent drop in the pregnancy rate. Live birth rate, clinical pregnancy rate, both dropped by about half, and more than a 2.5-fold increase in the spontaneous abortion rate among cigarette smokers. These were all statistically significant. And if you look at cotinine in the follicular fluid, cotinine is the main metabolite of nicotine in cigarettes. Nicotine has a very, very short half-life. It's unstable. It's difficult to measure. But cotinine is very stable. And at least in the urine, it'll persist in the urine of a cigarette smoker for a month after she stops smoking. And what you can see from this study is roughly a linear decrease in the number of eggs retrieved with increasing concentrations of cotinine. And this is at the level that matters. This is the follicular fluid that bathes the oocyte. Now, what happens if the patient herself does not smoke, but she's exposed to secondhand smoke? Maybe her partner at home or somebody else in the home smokes. Maybe there's smokers at work or in an environment in which she's frequently active. And you can see this from this study from the United Kingdom. There was no change in fertilization rate when you compared secondhand smokers to smokers, to non-smokers. But the pregnancy rate dropped by more than half, and the implantation rate dropped by half in patients who were exposed to secondhand cigarette smoke. And what I find most interesting about this study is if you compare those who were exposed with secondhand smoke compared to those who smoke themselves, the pregnancy rates were virtually identical, as was the implantation rate. So from this study, we conclude that exposure to secondhand smoke is just as bad as smoking yourself. This was a study that we undertook at Brigham and Women's Hospital, nearly 2,000 of women, and we looked at the concentrations of the same metabolite we talked about before, cotinine. And what we found was there was a 50% increase in implantation failure, in other words, less implantations, and a 25% reduction in live births in the patients in whom we could measure cotinine in their follicular fluid. Now, what about the male? What happens if the male smokes? And this study comes from Germany, where they looked at pregnancy rates among men who smoke in IVF. And what you see is a decrease in the pregnancy rate of more than half among the partners of men who smoked. And perhaps more importantly, that difference is not overcome even if ICSI is used. So again, cigarette smoking in the male, also not good. Now, is the effect on the oocyte, we've talked about the effects on follicular fluid, or is the effect on the uterus? And this was a novel study that was done by the IBI group almost 20 years ago. And what they did is they looked at donors who were non-smokers. So this would be the oocytes, and then recipients that they divided into three groups: non-smokers, what they called non-heavy smokers, less than half a pack a day, and heavy smokers. Unfortunately, when they did the analysis, they only looked at heavy smokers and non-heavy smokers. And what they found was a significant drop in the pregnancy rate, although not a statistically significant drop in implantation rate and miscarriage. So this implies, because the difference was only in recipients, that there is also a uterine mechanism that's at play here. So thinking about the mechanisms once again, I've shown you that there's a reduced implantation rate in cigarette smokers. There is impaired folliculogenesis, and the mechanism is at least twofold. One is inhibition of granulosa cells aromatase by elements in tobacco smoke. Because the aromatase is inhibited, there's increased testosterone. So with less estrogen and more testosterone, that's an unfavorable environment for the oocyte. Some of that work was actually done in vitro by our chairman, Dr. Robert Barbieri, many years ago. It's also well known that there's premature depletion of the oocyte pool. And in fact, women who smoke cigarettes go through natural menopause approximately 2 years before their non-smoking colleagues. And of course, cigarette smoking increases oxidative stress. So at a cell level, that's not a good thing. So in conclusion regarding cigarette smoking, we can say that smoking reduces IVF pregnancies by approximately 50%. I tell my patients it's a pretty good form of birth control. Smoking increases miscarriages about 2.5-fold, and both secondhand smoking and smoking in the male partner also reduce IVF success. So let's take a look at alcohol. So this was a very large study. We're going to come back to the study several times that we undertook at Brigham and Women's and 2 other Boston IVF programs in the mid-1990s and early 2000s. And as you can see, the numbers are very high. This was supported by 2 grants from the National Institutes of Health. We looked at more than 2,500 couples who underwent nearly 5,000 cycles of IVF. And in this portion of the study, we looked at their alcohol consumption. And what we found was that a little bit more than half of the women were really not drinkers, less than a drink a week. About 40% were mild drinkers, and 4% were heavy drinkers, drank at least daily. Here are the numbers on the men, and about 9% of men were heavy drinkers. When we looked at what they consumed, beer, red wine, white wine, hard liquor, it was about the same for all, both men and women. Now, this is the important data from this particular study. As you can see, among both women and men consuming 4 or more drinks a week, and this is very important, this is the month prior to the patients going through the IVF cycle. The live birth was decreased by 16% if the women drank, 10% if the men drank, but it did not reach statistical significance, and about 21% if both the men and women drank alcohol. Now, that study has been followed up by this study, which was done at the Harvard School of Public Health and Massachusetts General Hospital. They had a cohort of 300 women who were prospectively followed over a period of many years. It took them a long time to do the study. Alcohol was only a small part of the study. They were interested in a very, very detailed dietary food frequency index. Patients filled out frequent indications of what they were drinking, eating over a long period of time. Important in this study, the temporal relationship to the actual IVF cycle is not clear, and they recorded the amount of alcohol consumed in grams per day rather than glasses of alcohol. But 12 grams is about 1 glass of alcohol. In their study, no difference whatsoever in the live birth rate, whether it was half a glass of alcohol a day, half a glass to 1 glass, 1 to 2, or more than 2 glasses of alcohol a day. In this study, also in patients enrolled in Boston, drinkers were classified as non-drinkers, social drinkers, so very light drinkers, or daily drinkers. And what this particular study found was a higher miscarriage rate among drinkers compared to social drinkers or non-drinkers. There was, however, no difference in cumulative live birth. So why are there different results regarding alcohol? There are big differences in the sample size. Our sample, as you saw, was nearly 5,000 IVF cycles, 2,500 couples. The way that the cutoffs of alcohol were calculated was different. The amounts of alcohol in the studies were different. But I think most importantly, when the patients drank in relation to the IVF cycle is different. And in our study, we looked at it just before they began their IVF cycle. So in conclusion about alcohol, in the United States, about half of women undergoing IVF drink, about 2/3 of their male partners drink. And from our data, at least, live births may decrease for women and for couples consuming 4 or more drinks a week, although I've shown you there is some controversy regarding those data. And I believe that the risk appears greatest if the consumption is immediately before the IVF cycle. I think that makes sense. All right. What about my beverage of choice? I can hold up my coffee cup here if we stop screen sharing. I'm afraid to stop screen sharing, so we won't. But this is caffeine. So the first study I want to share with you comes from the Middle East. This one was from Saudi Arabia, where they looked at more than 600 women who were undergoing IVF in Saudi Arabia. 97% of the women in this study consumed caffeinated beverages, mostly coffee, and the mean caffeine consumption was about 4.5 cups of coffee a day. These women drank a lot of coffee. This study found no association between caffeine consumption and pregnancy rates. There was a decrease in the number of eggs as caffeine increased, but no change in the pregnancy rates. Caffeine consumption in this study was associated with miscarriage, and that's very well known. So American College of Obstetrics and Gynecology, American Society of Reproductive Medicine strongly encourages pregnant patients to reduce their caffeine consumption to 200 milligrams a day or 2 small cups of coffee a day or less. So this was a study again, utilizing the same database, the large study that we did, supported by the NIH. And for this element, again, nearly 5,000 cycles were looked at. Using those who drink basically 1 cup of coffee a day or less as the base, there was no difference in pregnancy rates, live birth rates among moderate coffee drinkers, 1 to 2 cups a day, or those who drank more than 2 cups a day. There was a lower estradiol level at the time of trigger, but no difference in the total number of eggs, fertilization rate, or implantation rate. So again, no effect of caffeine. This again is the study from Harvard School of Public Health, Massachusetts General Hospital, and they looked at live births after caffeine consumption. You can see the cutoffs here, but no difference whatsoever in live birth. And finally, a study that was done by one of our former research fellows, Ranit Makhtinger. This was done in Israel at Shiva Medical Center in Tel Aviv. And she did a very, very careful assessment of beverage consumption among more than 300 Israeli women, looked at 7 types of coffee, 2 types of tea, chocolate drinks, and even soda, and very carefully calculated out how much caffeine is in each and reported her results by quartile. And in looking at caffeine consumption, there was no difference in the total number of eggs among the 4 quartiles, no difference in the number of top embryos, and most importantly, no difference in the live birth rate. So, in conclusion regarding caffeine, I think we can probably say that caffeine does not reduce live birth rates. And as I mentioned, there's abundant data that caffeine consumption increases miscarriages. So to move on to diet, there's a lot written about diet and infertility, and a lot written about IVF and infertility. And the World Wide Web is full of recommendations regarding diet. And my patients, at least, come in telling me what they have read and what they want to do. The actual data on diet are much, much harder to find. And I will share with you just 2 studies, and you'll see that even these studies really have borderline significance. This one comes from the Netherlands, looking at 200 couples undergoing IVF, and it was based on whether patients did or did not follow the recommendations of the Netherlands Nutrition Center, which asked individuals in the Netherlands to consume 6 groups of foods each week, whole wheats, mono and poly unsaturated oils, vegetables, fruit, meats, and fish. And there's a scoring system for how well they adhered to the recommended diet in the Netherlands. And as you can see from this slide, the women who adhered to the diet had a slightly better pregnancy rate than those that did not. There was no difference if the men adhered to the diet. And this study comes from Serbia, looking at those doing a Mediterranean diet. So 161 couples completed a food questionnaire with nearly 200 items, and 2 dietary patterns were compared. Those who had a health conscious diet, so that's a good diet, low processed foods with high intake of fruits, vegetables, fish, and whole grains, and those who followed a Mediterranean diet, again with high intake of vegetable oils, vegetables, fish, legumes, nuts, lean meats. So there was no difference, no reduction really, although it was a borderline significance in pregnancy rates with those following the health conscious diet. And there was a very slight increase in pregnancy rate, again at borderline significance, for those who followed the Mediterranean diet. So not much we can really say about diet, but a balanced diet may increase pregnancies. That's the Dutch study. Mediterranean diet might improve pregnancy rates. There's a little bit more data now in Mediterranean diets, but I think that that's still somewhat speculative. That being said, all patients should be encouraged to follow a healthy diet. Finally, we're going to talk a little bit about exercise. This is a study done by Lauren Wise when she was with us. She's now a professor at Boston University. And for a long time, she had been working with collaborators in Denmark. And these were patients who were planning pregnancy. And she divided their exercise into 3 groups: those who did vigorous exercise, such as running, fast cycling, aerobics, gymnastics, swimming, those who did moderate exercise, such as brisk walking, leisurely cycling, golfing, or gardening. I don't know about you, but I don't know that gardening is really moderate exercise, but maybe those in Denmark garden very vigorously and it reaches the moderate range. Lastly, those who did not exercise at all. And what you can see from this slide is that there was no difference in pregnancy rates among those who did moderate exercise, but there wasn't a decrease in pregnancy rates. And the variable she used was the fecundability ratio, which is the chance of pregnancy in 1 month. There was a 16% reduction in individuals who exercised 2 hours a week, and a third reduction, 1/3, in those who exercised 5 or more hours a week. And if you look at it graphically, although it's somewhat of a wavy line, there's almost a linear decrease in pregnancy rates with increasing hours of vigorous physical activity. So again, from this very large cohort that we had in Boston, we looked at exercise, and this was about 2,200 patients. These were good exercisers. 61% of our patients exercised. They had been exercising on average for more than 11 years, and they devoted 4 hours a week to exercise. The type of exercise they did: walking, aerobics, jogging. I guess we call that running today. And this was in Boston. We have a lot of bicyclists and a lot of people who row. So 8% in those categories. And we divided the exercise into 5 groups: those who did not exercise, those who exercised 1 to 3 hours a week, up to 9 years, those who exercised for 4 or more hours a week, up to 9 years, those who exercised 1 to 3 or more than 4 hours a week for more than 10 years. So this slide is a little bit busy, but I want to show you that the statistical significance was almost exclusively in the category 2 subjects. And these were the ones who exercised 4 or more hours a week for up to 9 years. So this was not our heaviest exercise group. So there was, if you will, a lack of a dose effect of exercise on IVF outcomes. And the statistical significance pointed in the direction of lower pregnancy rates. There were more cycle cancellations, more implantation failure, more miscarriages, and less live births. We also, when we looked at the type of exercise, found a 30% lower chance of live birth for those who did cardiovascular exercise. None of the other forms of exercise reached significance. So we had a lot of difficulty trying to explain what's going on here because, as I said, there was not a dose effect. We saw a nonlinear effect of increasing exercise. And then we scratched our heads to try to figure out why that might be. It might be that shorter frequencies was sufficient. But again, those who were in the shorter duration of exercise could have exercised up to 9 years and still be in that group. Maybe the body reaches equilibrium, and after a certain amount of time, the exercise is no longer important. From a reproductive point of view, our data simply don't let us distinguish. So this remains a little bit of a puzzle, at least to me. So this was again work by Lauren Wise looking at men. She again used the same database that we've been talking about 4,500 fresh semen samples, and she found no effect of exercise and semen parameters, with one exception: men who bicycled more than 5 hours a week did have lower sperm counts. So now we come to my favorite study in the entire presentation. This one was published in the British Journal of Sports Medicine, and it looked at a little less than 200 men from Rochester, New York. That's upstate New York, not New York City. And it looked at their physical activity in regard to semen parameters and divided the men into quartiles, with the highest quartile being the most exercise. These men did 15 hours a week or more of moderate to vigorous exercise. And those men had a 73% higher sperm concentration than the men in the lowest quartile for exercise. But now my favorite statistic: the men in the highest quartile for television watching, those men who watched 20 or more hours a week, and that's about 3 hours a day of television, had a 44% lower sperm concentration than those men in the lowest quartile who did not watch television. So my recommendation when you speak to your patients is to tell them to have their husbands turn off the television and stop watching cricket, because that will help their semen parameters. So finally, about exercise, vigorous activity leads to increased time to pregnancy. That was Dr. Wise's study. Moderate exercise, especially cardiovascular, may, I'm not certain it's true, but may decrease IVF success. And physical activity, with the exceptions that we've noticed, does not diminish semen parameters. So what did we learn in conclusion? Cigarette smoking and moderate alcohol consumption probably reduce IVF success. Healthy and Mediterranean diets might improve IVF outcomes. I think it's helpful to review modifiable risk factors with patients. They do ask this. And I think for the physician, we can use these data to be potent motivators to change behavior. Patients are often very, very motivated if they're having difficulty conceiving to make changes in their lifestyle, because it has a very immediate impact. If we tell someone to stop smoking and exercise because 40 years later it might prevent a heart attack, that's very far in the future. But if we tell a patient that if she stops smoking, that her pregnancy rate may improve by 50%, that's immediate. So I think at this point, time remaining, I'm very happy to answer any questions. And thank you for allowing me the honor of presenting to all of you this morning, or in your case, this evening.